So at this juncture, we would be tackling all about the alveolar bone. So alveolar bone or alveolar process is part of the maxilla and the mandible that forms and supports the sockets of the teeth. On the left side, we would see the alveolar process of the maxilla, and on the right side, we would see the alveolar process of the mandible. It is where our teeth are embedded. For the functions of the alveolar bone, it houses the root of the teeth. It anchors the teeth with the help of Sharpie's fiber, as we have discussed in the cementum, helps to absorb and distribute occlusal forces in terms of biting and chewing, supplies vessels to PDL, organizes eruption of primary and permanent teeth, and lastly, it protects developing permanent teeth while supporting the primary teeth. Development of alveolar bone. Near the second month of fetal life, the maxilla and mandible form a groove that is open towards the surface of the cavity. It originates through the process of intramembranous ossification involving mesenchymal cells from the tooth germ. So, mesenchymal cells can be differentiated such as osteoblasts for bone, chondrocytes for cartilage, and the likes. Intramembranous ossification refers to the transformation of mesenchymal tissues directly to bone. Major changes in the alveolar process begin to occur with development of roots and tooth eruptions. As roots develop, the alveolar process increases in height. In order for the alveolar bone to protect the teeth, it needs to reach the height of the root of the teeth. It is important to realize that during growth, part of the alveolar process is gradually incorporated into maxillary or mandibular body. The alveolar process forms with the development and eruption of teeth, and conversely, it gradually diminishes in height after loss of teeth. To those patients who are edentulous, the alveolar bone tends to diminish or deteriorate in height.
Good day, I am Kay and I am about to discuss the structures of the alveolar bone. The alveolar bone can be distinguished into parts. The alveolar bone proper, which forms the socket of the tooth. The supporting alveolar bone that forms the structure around the alveolar bone proper. When the socket wall in the alveolar bone proper is seen under the microscope, it shows numerous perforations due to which it is also called the cribriform plate. It is through these perforations that blood vessels and nerves enter and exit the periodontal space. Histologically, the alveolar bone proper can be further divided into bundle bone and lamellated bone. The root of the tooth is lined by the cementum. Between the cementum and tooth of the socket is a periodontal ligament, and in the periodontal ligament are the principal fibers. The principal fibers on one end are embedded in the cementum, and on the other end it is in the alveolar bone proper. So the bundle bone is that portion of the alveolar bone proper in which the principal fibers or the sharpest fibers are embedded. The lamellated bone is that portion of the alveolar bone proper in which no principal fibers or sharpest fibers are embedded.
The supporting alveolar bone consists of two parts. First is the cortical plates. These plates form the outer and inner plates of the alveolar process. They are generally much thinner in the maxilla and thickest in the premolar and molar region of the lower jaw, especially on the buccal side. Next, we have the spongy bone. This fills the area between the cortical plates and the alveolar bone proper, and there are two types of it. The type 1 shows regular and horizontal ladder-like arrangement, and in the type 2 it is irregularly arranged, numerous, and delicate. Now we have the crest of alveolar septa or the alveolar crest. This is where the cortical plates and the alveolar bone proper meets, and the shape of outlines is dependent on the position of the adjacent teeth. The alveolar crest is around 1.5 to 2 millimeters below the CEJ in healthy mounts.
Ternary constructions of alveolar bone takes place during eruptive stage of the tooth bundle. Deposition of bone at alveolar process or base of the socket. Bundle bone is deposited, which shows presence of numerous of resting lines. Mesial drip of tooth. There is resorption in the mesial direction of bone, but not the entire mesial surface. Period of resorption alternate with period of rest and repair. The position of the distal direction, that is the internal construction of the bone during the mesial drift, the resorption and deposition. During the changes, formed compact bone may be replaced by spongy bone, and spongy bone may be replaced by the compact bones. In this illustration, we can see the dentine, cementum, periodontal ligament, as well as the bundle of bone separated to the lamellated bone by the reversal line.
Good day to everyone. I am Dane Daniel M. Padua, and I will discuss the age changes in alveolar bone and clinical considerations. As we age, there is a gradual decrease in our bone mass. The causes are decrease in osteoblast proliferating precursors, decrease synthesis and secretion of essential bone matrix proteins. Extracellular matrix and fibronectin are very important, and damage of these might cause dysfunction and are responsible for reduced bone formation. Loss of alveolar bone is rapid and more extensive in mandible. Losing our teeth increases with age, period of absence of dentures, resulting in decreased facial height with upward and forward positioning of mandible. Bone is a biologically highly plastic tissue. Its plasticity that enables the orthodontics to move teeth without disrupting their relations to alveolar bone. Bone is reabsorbed on the side of pressure and opposed on the side of tension. On the sides of compression, osteoclasts proliferate and initial reabsorption of the superficial bone takes place. At the sides of tension, osteoblasts are activated to produce osteoid that subsequently mineralizes to form new bone. During healing of fractures or extraction wounds, an embryonic type of bone is formed, which only later is replaced by mature bone. The pattern of resorption is different in maxilla and mandible. In mandible, it resorbs downward and outward. In maxilla, it resorbs upward and inward. As for resorption of alveolar bone after tooth loss has been assumed to be due to disuse atrophy, decreased blood supply, localized inflammation, or unfavorable prosthesis pressure.
Good day, I am Kimberly B. Pagdansolan and I will be discussing the therapeutic considerations in the alveolar bone. Bone grafting, it involves a surgical procedure to place bone or bone substitute material into a bone defect. The purpose of this bone grafting is to produce new bone and the regeneration of periodontal ligament and cementum. It provides bone for the eruption and for orthodontic repositioning of the teeth, closure of oronasal fistulas, support and elevation of the alar base, and provide continuity of the alveolar ridge. Now we have different types. First is the autograft. It utilizes the patient's bone which can be obtained from intraoral or extraoral sites. These are within the mouth and outside the mouth. And materials for bone grafting are very well accepted by the body and may produce the fastest rate of bone growth. Next, the allograft. It is obtained from another human source. These are highly processed bone powder from human cadavers. Heterograft. These are obtained from animal sources such as cows and pigs, and they include processed animal bone or growth proteins. In those cases where bone graft from human or animal sources are not feasible, synthetic graft materials are used, or what we call the alloplast. We have epithelial exclusionary technique, which is a guided tissue regeneration approach and facilitates the cells of the periodontal ligament to differentiate into osteoblasts, cementoblasts, and fibroblasts. Lastly, we have biologically mediated strategies, which includes materials such as animal matrix proteins. These are intended as an adjunct to periodontal surgery for topical application on the exposed root surfaces or bone to treat intrabony defects. We have two types of scaffolds, the osteoconductive and osteoinductive.